Aire, you Hasini Pravarika.
Hello, Alice.
Yeah, I'm changing the settings as well. So only the co-host can unmute and speak. We're live on YouTube and we can start the session. Good evening, everyone, and welcome to today's special webinar. Indian Academy of Pediatrics is celebrating World Obesity IAP Day, which we're celebrating this year. And Obesity Day, I would call it as the pandemic ahead of us. We've been through 2 years of COVID pandemic, and it has left a lot of scars on us. And one of it has been on the health of children. And we are expected to see a lot of its effects, both mentally and physically. And obesity is likely to be the next big pandemic ahead of us. Important for us to raise awareness amongst pediatricians that this is a problem. This needs to be addressed. We need to find a solution. And also to raise awareness amongst parents so that they consider obesity as a disease and not just being chubby. We have a very interesting panel discussion today. And before I hand it over to them, I'll request our president, Dr. Sunkoj Bhaskar sir, to please give his remarks. Dr. Bhaskar sir, please.
Yeah, thank you. Thank you, Dr. RSC. Am I audible?
Yes, sir. Go ahead.
Yeah, thank you very much. At the outset, I welcome all the participants of this webinar on behalf of IAP Twin Cities branch and as well the Adolescent Health Academy, Hyderabad. I'm grateful and thankful to AHA for associating with us to do this relevant program of the day, that is World Obesity Day. I'm happy to see the faculty led by Dr. Preeti Nagaraj will be moderating the session, and Dr. B. Anita, the secretary, and as well she is also moderating the session, and the panelists are our IAP National Executive Body member, Dr. Sri Sailam, Dr. Kishore Bhaskar, the young upcoming endocrinologist, and Dr. M. Renuka from Mumbai, a nutritionist. Yeah, the importance of obesity, as we all know, more than these communicable diseases, now we are seeing more prevalence of non-communicable diseases. In future, probably most of the diseases are related to non-communicable diseases. Particularly the obesity has become an international public health issue, particularly more so in children. The majority of the obese people are in the pediatric population. So therefore, it's high time for us to think about this problem and to take the measures required for it, like nutrition, physical exercise, and behavioral therapy. And I'm sure our eminent faculty will throw more light on this. With these few remarks, I once again welcome you all to this very useful webinar. And special thanks to Dr. Preeti Nagaraj, the president of AHAH. Wonderful name, AHA. So I welcome you all, and I hope you'll have a great learning experience. Thank you, one and all. Over to Dr. RSC. Thank you.
Thank you, Bhaskar sir. Thank you for joining us amidst your busy schedule. Hand it over to Dr. Preeti and her wonderful team. Look forward to very interesting deliberations and discussions. We'll try to open up the chat box from the beginning so that you can interact. And Dr. Preeti, probably towards the end of your discussion, let us know, and then we'll enable it for all participants to unmute and also speak. The floor is yours. Over to you, ma'am.
Thank you so much, Sri Krishna. And at the outset, I would like to thank the president and whole team of TCB who have just gladly given us a chance. I just said that we have just started this AHA and it is yet to be filled. The posts are still open and we are just getting into that. And he said yes, and that is very relevant that we had a World Obesity Day yesterday. And he said, why don't you conduct some panel discussion or something? And our endocrinologist Kishore, who is known in our TCB circle. He is a very renowned endocrinologist. Very regularly he agreed. And when I was searching for a nutritionist, I thought, why not? I asked my friend, because last minute it was. So, and Sri Shalam, our central IAP executive, but so readily is agreed. Okay, madam, because the cause is so much. So everybody wants to act together. Everybody needs to act together, and this everybody knows. So we are all dedicated to the cause of obesity. So without wasting much time, let me share the screen. Thank you all participants for joining, and kindly note the questions at the end of the session. We have a open forum where you can interact with the endocrinologist, the nutritionist, the wellness expert, Dr. Sri Shalam. And Anita is there to moderate all the questions. So I'll be just sharing the screen.
I request all the participants to drop their questions in the chat box. We can discuss them at the end of the session.
Are you all able to see my screen?
Yes, ma'am, it's visible.
Yeah. So before going to the session, I would like to quickly introduce my panelists today. Kishore Baske, everybody knows, is a pediatric endocrinologist working in Little Stars and Hope Children Hospital in Hyderabad. He is a very good academician who visits Nilofer oftenly and guides us in our cases. Then he has a number of presentations in his kitty, and his special interest is on PCOS and diabetes and DSD, and obesity definitely is his interest. Sri Shalam, everybody knows, is our central IAP executive member. He is a BLS instructor. He is an RP. He is into all the module preparation for Mission Laksha and empowering Yuva. He was a ground worker for the Yuva when it came, when we were doing in every districts. We were doing the Yuva program, going directly to the schools and educating and interacting and creating awareness among Yuva in the schools. Sri Shalam had a great big role to roll out this program. So, and he is the secretary for Nizamabad branch. In fact, he has a meeting at 9:30, but still he agreed. Thank you so much, Sri Shalam. Renuka, my dear friend, who is a corporate nutritionist. He's an she's academic counselor also. So without wasting, I just want to ask the panelists the very first question. Can I ask others to please mute? Can I ask others to please mute? Please.
Yes, ma'am.
Can I ask you, what is basically obesity and what are the different types of obesity?
Good evening, all.
Just a second, Dr. Sri Krishna, can you mute everybody? But for the panelists, how to do it? Just a second.
In 2019 at St. John's, we have written a paper in collaboration with all the sensors, Dr. Jacob, Dr. Bhaskar.
Ma'am, can I?
Yeah. Yes, Dr. Krishna.
Yeah, thank you, ma'am. Good evening, all. And before going into the presentation, I would like to thank IAPTCB President Sunko sir, RSV sir, and Preeti ma'am and AHA team of Telangana branch for giving and organizing such a wonderful program today. Of course, even though we are one day delayed, but we are presenting this presentation on behalf of World Obesity Day. So everybody knows, like, obesity means excess weight. Is it true? Obesity and excess weight both are not same. It's a condition of abnormal or excessive fat accumulation in adipose tissue to the extent that health may be impaired. So excess weight and obesity are not same. Next slide. So it is an emerging problem and it is no more, it is a simple endemic or localized disease. Now it became a pandemic, especially post-COVID. It is not a problem of a disease of children, even it affects adult life also. And almost 5 to 10% of the total healthcare cost is going to be spent on obesity. It is not only prevalent in developed countries, even in developing countries also, obesity is emerging, and now it became pandemic. So everybody knows, most of the people think that obesity is a problem of urban and western, but it is wrong. Now even it is existing in rural areas, even developing countries like India is also more rampant. Like, of course, there is a minor difference in affluent countries, affluent states, it is more prevalent when compared to rural background. Coming to the Indian background, even though there are two different studies, from one is north area from Delhi and central part of the India from Pune, more or less 25 to 30% of the Indian children are overweight, whereas 10% of the children are obese. So 25% of our Indian children are overweight and 10% of the Indian children are obese. So next slide, mates. So coming to the type of obesities, even though this definition is not applicable to children, even though we more common talk about different types of obesity, especially in adult, there are two types of obesities. That is, one is android obesity, also known as central obesity, and second type of obesity is gynecoid obesity. So in android obesity, fat accumulates in the upper segment, that is upper part of the chest. It is also known as apple-shaped obesity. And who are having more of apple-shaped obesity, they are more to have metabolic syndromes, diabetes, hypertension, and they do have waist-hip ratio is more than 0.8. Whereas a gynecoid obesity, it is because of the more subcutaneous fat, more accumulation of fat in the thighs and the lower segment. It is also known as pear-shaped. And when compared to android obesity, complications are fewer. Next slide. So whatever I have explained, it is a pictorial representation. In apple obesity, upper segment of body is involved, whereas a pear-shaped, lower segment of body is involved. In apple type of obesity, metabolic complications are more common. Thank you.
So, a very good question for Dr. Srishalam. What are major causes of obesity? Sometimes patients come that this obesity is there in my family. It runs in my family. Actually, nobody runs in the family. That's why they are obese. So, apart from these jokes, yes, Srishalam. So, what are the major causes of obesity? According to you, no physical activity, sedentary life. Dr. Srishalam?
Yes, ma'am.
Yes.
Good evening.
Yeah. So,
I first of all like to thank the TCB team led by Dr. Sunkoj Bhaskar sir and Dr. R.S.V. Sri Krishna for giving me this opportunity. And I thank you also for being so cooperative and helpful. Today's talk is truly the need of the hour, as we see that no more, it's not the obesity is no more the problem of the West. Even we see that so many obese children, it's creeping up in Indian subcontinent too. So I think it's right time to talk about obesity. Now, whatever might be the cause, where we divide it as exogenous and endogenous. The main thing is whenever there is an imbalance between the calorie intake and the expenditure, that leads to the problem of obesity. So the various endogenous causes could be a genetic one or the endocrine causes, which could be approximately 10% of the cases. But we should also know that majority of the time, it is the exogenous, which is what we want to stress upon. Now, in the endogenous causes, again, there are various causes like Cushing syndrome, the hypothyroidism, hyperinsulinism, pseudo-hyperparathyroidism. So all these things. And if you look at the genetic causes, the Prader-Willi syndrome, Lawrence-Moon. So all these are one. So in them, either there could be there is an excessive hunger or the fat metabolism is hampered. So ultimately, it leads to either overeating or the metabolism of fat oxidation does not take place. So regarding the exogenous ones, what we generally say, environment plays a very big important role, and epigenetics. The role of exogenous factors is so high that those people who are predisposed to genetically to obesity, we can at least modify their life modify their and at least halt the progress of the obesity. So the occupation, be it the lifestyle, depending on the energy intake, eating behaviors, inactivity, smoking, sleep duration, the chronic stress, all these are the environmental factors wherein obesity, it could lead to obesity.
Thank you, Sri Sharam, for nicely highlighting all the causes. Can I ask, these are all the genetic causes, which again I will ask Kishore also to highlight. My question to Dr. Renuka is, pandemic has seen a pandemic of obesity. Is it not so? So many obese because of lockdown. And then you would have had n number of calls by the mothers saying that yes, during COVID, in the initial first wave, everybody started to cook. And we in TCB also had a program, cultural program, seeing that everybody is cooking, dancing, and the whole family is involved. And then later it led to that obesity. So what are all the questions you encountered, Renuka, and what was it? How did you handle it?
Yeah, at the outset, I want to thank Dr. Preeti Nagaraj ma'am and of course the team of IAP and AHA for giving me this opportunity to join you all from Maharashtra. We have seen the pandemic for last 2 years and we have realized the health is really precious. Now, pertaining to the lockdown, initially, if you see the market flow of the food material, it was all centered towards the carbohydrates, refined carbohydrates. And, everybody started, even the social media handles was flooded with hashtag home cooked food. The ladies busy were preparing their different delicacies, cuisines, which were flashed everywhere. So if you see, there was a reduction in the physical activity. Similarly, there was an intake in the food intake. Now that has definitely seen the rise in obesity among the general population as such. We have definitely seen the pediatric obesity, but of course we have seen a general obesity in the community as well. Now, since the people were, and if you see the Indian pattern, I always say that our India is a young country, but fortunately, we don't want it to be a sick young population. And obesity is a root cause of, many diseases. All our doctors have already stated. So, the obesity leaves a slim chances for the community to remain healthy. Now, as it stated, or Dr. Preeti has also stated, nobody runs in the family, and our Indian eating pattern is seeing the transition. We have been eating more of a carbohydrates, more of a sugar, and that has brought a drastic change in the eating pattern. And of course, the television advertisement has got another impact on the eating pattern of the young generation. So, the eating pattern has definitely seen a drastic transition pertaining to this pandemic situation.
So from this, you want to say that the excess of fat is deposited here and there, and you had,
of course, yes, even the sir has said there is a excess body fat, ectopic intra-abdominal fat is also there, subcutaneous fat is also there, and definitely the carbohydrate needs to be blamed for that, and the fat, basically carbohydrate and the fat are the two culprits. Unfortunately, Indians eat very less proteins.
True. So we have to begin this journey of this. Will you be saying how we have to? I mean, it takes a long time for a person, and all of a sudden standing on the crossroad whether to go on this side or that side. So nutrition transition definitely. So it has to be replaced.
Nutrition transition, and just go back to earlier slide, Dr. Preeti. I always say that your taste bud rules everything. Your tiny tongue controls your 5 foot 10 inch body. Nutrition comes second. Your taste rules everything. So if you really control your tongue, definitely there are many things which can be prevented. So that's what. And then of course the nutrition transition. In general, also we are seeing the nutrition transition. We all should be really happy that our Indian plate. Initially, there used to be a food pyramid, but food pyramid is replaced by my plate. And my plate concept has been taken from the Indians. So aren't we proud of that? Our Indian thali has got everything: prebiotic, probiotic, protein, carbohydrate, fat, fiber. But that has been replaced by something which is unhealthy. So, we are moving towards more of a conventional eating, ready to eat food. So that is creating the major transition and problem for the, future generation and the present generation.
Okay. Nice that our thali is really been recognized. Many habits during COVID, Indian traditions and Indian habits were recognized, like your namaskar, and our hygiene was good. And that was really applauded by the whole world. World was looking towards us. Yes.
Right.
So next question to Dr. Kishore. I will give one case scenario when an adolescent boy, 10 years of age, he has a BMI of 22. I want to know how are you going to evaluate, and I want to know something about the body mass index. How do we calculate what it is? So please highlight on this, Dr. Kishore.
Yes. Yeah. Next slide, ma'am. Yeah. So now why we are using BMI? We want to measure and we want to grade the obesity, whether it is a mild, moderate, or severe, so that we can assume any perimorbid conditions or complications in the future. So obesity actually should be assessed by the basis on the fat content, not on the basis of weight. So actually by doing BMI, fat cannot be measured. So it is not a true anthropological marker of obesity assessment. It is a surrogate marker of obesity assessment. It is not going to tell a person who is having excess fat, because of that child he developed obesity, or maybe he is obese because of the excess muscle or bone mass. So BMI is not going to
that we estimate the lean body fat?
No, madam, it is not going.
DEXAs?
Yeah, ma'am. So by DEXA scan or some computer tomography and specialized ultrasounds, actually they supposed to do for the assessment of the lean fat measurement. But unfortunately, because of the easily available and easily accessible for the pediatrician or healthcare practitioner in like calculating BMI, it is most commonly and robustly used by the many of the individuals. So body mass index is measured by weight in kg divided by height in meter square. So BMI not only tells about the obesity, it also tells about the thinness. So as per the IOTF guidelines, which is published in 2014 and 15, so the ideal expected BMI should be 18.5 to 24.9. So any individual who are having BMI less than 18.5, we call them thin. So mild thin, moderate thin, severe thin, there are grades, but I don't want to go in detail. But less than 18.5 of BMI indicates thinness. Whereas a BMI of more than 25, this is for the adult, whatever the cursor I'm showing and then telling. So overweight of 25 to 30 we call overweight, more than 30 we call as a obesity. So it is for the Western population, whereas American population, whereas for the like Eastern countries, especially Japan, China, and also to some extent India, we have to call BMI of more than 23 as a overweight, more than 27 as a obese. These are the Indian and Asian cutoffs. So similarly for children, we are using recently growth charts. So in next 1-2 slides, I'm going to tell, but please keep this slide like this only, ma'am. So 23rd equivalent, we call it as overweight. 27 equivalent centile chart, we call it as a obesity. So as per the centile, any child having weight crossing above 85th centile will call as a overweight. Any centile more than 95th centile will call as a obesity. It is one way of like grading the BMI. Madam, next slide. Yeah, so BMI more than 85th centile call as overweight, BMI more than 95th centile call as obesity. So it is applicable to all children about 2 years till 18 years of age. Whereas for children less than 2 years, we have to use weight for length charts. So what are the other markers? What are the other anthropometric measures we can use to classify the obesity? Is the best marker is waist circumference. Unfortunately, there are no standards in India, but recently Dr. Vaman Kadilkar, who published in 2014 and 15, he also published waist circumference centiles. So for Indian, we can't keep 95th centile as obesity. More than 90th centile, we have to call them as obesity. And similarly, more than 70th centile waist circumference, we should keep for the evaluation of the children for the metabolic syndrome. So not only waist circumference, waist hip ratio can also be used, skin fold thickness can also be used, and latestly people are using waist and height ratio. So any individual having waist height ratio more than 0.5 we call obesity. For example, 4 feet height child having 2 feet of tummy is definitely obese. So 120 centimeter height child having abdominal circumference of more than 60. So that is the definition of obesity. So not only BMI, we have to use the other surrogate markers like waist circumference, waist hip ratio, skin fold thickness, and even some physicians, they also use abdominal height. So child will be allowed to sit in the supine, lay down in sleep position. We will put a marker on the flat of the abdomen and we have to measure the length. So if it is more, then that is also indication of the visceral fat. So our aim is not only to address the obesity and BMI, we have to predict complications like metabolic syndrome. So we need to concentrate more on central obesity, that is visceral fat. So if we are able to assess more visceral fat, we are going to predict more complications in children in the future. Next slide, ma'am. So the actually recently published growth chart along with the height weight centile chart, there is also leftmost corner, there is a box which is a cubicle. It also mentioned yellow line and red line. Above the yellow line we call overweight, above the red line we call as a obesity. It is pink for the girls. Next slide.
This is for the boys.
So this is the like zoom slide. This is for the boys. Next, ma'am.
So
Yes.
Renuka, can you tell the diet management for this child who was a 10-year-old child?
Yes, absolutely. Now, as sir has already stated, we need to do the evaluation of dietary intake, what child is taking. Most of the time it is seen that there could be a skipping of 1 or 2 meals and there could be more consumption. And moreover, the child usually follows a small pattern, short break and long break. So in most of the short break period, it has been observed, and even the data has published that child is tend to eat more of a, crisp or probably biscuits or probably something which is convenient. Mothers doesn't want to cook. That is what been told to us by the children in the school itself when we were conducting the dietary intake evaluation of school going children. That was the very surprising results have come from the kids themselves. So, that small and long break creates a lot of problem. So that ultimately leads to the more consumption of calories. So we need to analyze the diet of the child. We need to give approximately 30 to 35%, 18 to 20% of protein, 40 to 45% of carbohydrate. It should be divided with, complex and simple and refined carbohydrate. We have to educate the mother to, incorporate more of whole grains like chapati, bajra, millets like bajra, ragi should be the part of the diet. The fat intake needs to be monitored properly, hidden as well as the visible fat. The visible fat, even the recommended intake for the visible fat is usually around 750 ml for a child per month. And for the adults, it is 500 ml per month. So you can do the calculation for the entire family. And accordingly, you can do the purchasing of the oil for the family. And then, of course, try and introduce the smaller, healthier snacks like, peanuts, roasted peanuts with a lot of salads in that, sprout, even chana. Chana is very good, loaded with fiber, calcium, iron, proteins. You can recommend eggs to the child and try to analyze the protein intake of the child. Very important. Cut down on sugar. Basically, sugar is not at all an essential component of the diet. Whatever you are eating, body is preparing sugar for you, preparing the energy which is required for you. So sugar is not at all an essential. People usually carry a myth that since I'm not diabetic, I can take sugar. But sugar needs to be restricted from the earlier stage itself, right? So try to have, and very important, which we usually miss out, is consumption of fruits and vegetables. So for the short break, I always recommend all the parents, give one banana or probably, the seasonal fruit which is available in your locality or in your area. So try and consume that. Try to reduce your food miles. Where was your food yesterday night? That is very important question you need to ask yourself. to your child. So you don't have to eat something which is convenience. Prepare the fresh food. Your traditional recipes like chuda made from different flax can be added, and it is supposed to be a healthier thing. And then try to have the nuts and oil seeds in the diet, and water should be regularly advised to the child to incorporate buttermilk instead of giving fruit juices. Recommend whole fruit, and buttermilk lassi can be given instead of your cold drinks.
So Renuka, thank you. You have nicely addressed the food what you have to give. But the child would say, Sunday to mere ko pizza hona, Sunday to mere ko burger hona. So what is your take on the processed food and Coca-Cola and burgers? The children do love burgers and pizzas.
Yes,
and,
absolutely.
Lockdown to made them to eat every day. They were eating every day like Sunday only. So now that the schools have started and you said long break and short break, what food we have to divide, right? But what about the Sundays, and what about the processed food? And mothers, as you said, they put the biscuits, they put the Maggie and all those things. So what is your take on the word on processed food? I want to hear from you.
Okay. So I just want to add, the processed food has become somewhat like a jargon. People usually use processed food everywhere. So processing is something which is required, from the wheat, you make wheat flour. So that's a required processing. Thus, you make a germination of your sprouts. That is a required processing. Processing which is bad is something from wheat I have made maida or the refined wheat flour. So that has leached out all my essential micronutrients out of that. And the consumption of sugar, salt, and of course the fat goes up. So now what is the solution? Supposingly your child demands pizza, try to add lot of vegetable, try to add paneer on that, try to add sprouts to that, make a fusion of recipes, and try and permitted combination. Now when usually I speak to my patients and they ask me what do you mean by occasional? We don't have to call something like cheat diet or the occasional diet. Do consume your meal, but balance that. Try to have pizza in the morning. So balance your evening meal with something like, low fat and probably like curd rice, or probably some dal and some boiled vegetables. Or if it is a chai, even you asked me about the, Maggi. So whenever you're preparing Maggi, try to add handful of green peas, French beans, carrot to that. So you improve the nutrition quotient of that particular recipe. So I always say, whenever your child is demanding something, biscuits. Now biscuits ke upar bhi you can always have a topping of some vegetable, probably cucumber and paneer grated on that. You don't have to always buy cheese. You can grate paneer on that. Don't buy tomato ketchup. Always apply tomato chutney homemade, which is loaded with lycopene, and it's good. So you need to be a little culinary innovative for your child, for your family, and there are lot many recipes are available which you can always do. And now the things have changed, like you can also have the chapati pizza or something like that, dosa pizza. So that can be definitely incorporated. So fusion and innovation could be the answer for that. And try to improve the nutrition quotient of every recipe.
So after hearing good nutrition tips from you that you can make it more nutritious, still you are going to give the junk and all those things. Can I ask Dr. Sri Shailam, what is the physical activity or what is the fitness plan you would give to these patients? Dr. Sri Shailam.
Yeah. I would like to congratulate the mother and the child himself for maintaining a very good body mass index. So that does not mean that no advice should be given to him regarding the physical activity, because any physical activity is a must for any child. Moreover, it really reinforces a confidence in them that his body mass index is appropriate for the age. So ideally what we have to take is collect the information, take the history from him, how this boy is able to maintain the body mass. So sometimes it might be that the calorie intakes are just sufficient, but his activity might not be that high. So that balance might be there because of the low calorie intake. Next, very important is if the child is physically active, like for example, how he walks to the school. Does the parents drop them or he walks on his own? So that includes as a physical activity. and how does he help with the household chores? Take information regarding that. So before prescribing, it is very important to collect the history to what all the physical activity the child does. So generally in physical activities, we know that there are 3 different types. One is the aerobic, the muscle strengthening activities, and the bone strengthening activities. Most of the children, what we advise to a 60 or more minutes per day should be either moderate or vigorous. Now this child fits in exactly from 5 to 17 years. So his accumulative of at least 60 minutes of moderate to vigorous activity is ideal. Now, once the child is already maintaining and is meeting the guidelines, it is definitely not advised to go for vigorous activities. So mild to moderate would be sufficient, because very aggressively doing more vigorous activity can really injure the child, can be more harmful also. So once he is meeting that guidelines, it is better to tell him to be active, continue all the activities what he is doing, but guide them, telling about the various aerobic activities, tell the parents about the muscle strengthening activities that should be included, that at least 3 days a week as a part of the 60 minutes of the activity. Now, bone strengthening exercises, like including the physical activities of at least 3 days of the week as a part of it. So what are the bone strengthening activities? What are the activities which we call it as a moderate and vigorous intensity? Whenever we talk about moderate intensity activity, the heart rate will definitely should be faster than the normal, and the breathing will be harder. The child breathing fastly, or it could be even normal. So a moderate intensity activity we call, when on a scale of 0 to 10, so somewhere between 5 to 6. Now in a vigorous activity, the heartbeat will be faster than the normal, and the breathing will be much harder than the normal one. So on a scale of 0 to 10, you tell him about 7 to 8. So these things should be briefed to the parents. Now regarding these various moderate to vigorous activities. So it is very important to always guide them to what routinely they can do. For example, muscle strengthening, the stretching exercise, for growth strengthening, jumping exercises, whether the child plays with the rope or stretches, pulls up. So all these activities can be collect from the history. If he is meeting the guidelines, I think definitely we should tell him to be similar way after activity, and guide him not to become obese, because in the Indian population, we see after the age of 8 years, there is a tendency of getting obese. So because of the various hormonal changes, I think the endocrinologist, what we have, Dr. Kishore, could tell why in the age of 8 years in Indian children, there are a lot of obesity prevailing. So thank you.
Yeah. Thank you so much, Kisharam. Next question I would like to ask Dr. Kishore, that this girl, 14 years old, mother has brought this girl with primary amenorrhea. She has not attained her menarche, and her body mass index is 28. Now, how are you going to approach this child? Yes.
Yeah. Next slide, ma'am. So whatever ma'am asked, she is a 14-year-old girl, BMI 28, and having primary amenorrhea. Now, the first question is, there are 2 problems to be addressed. One is BMI 28 indicating 14-year girl, she is definitely obese. Second problem is her amenorrhea. So as per the definition of primary amenorrhea, with attainment of secondary sexual characters not having period more than or equal to 15 years. So she is a borderline age group. Second, without having any secondary sexual character, not having period by more than 13 years, we will call as a primary amenorrhea. So now we have to look for, first of all, secondary sexual characters, whether they developed and stopped, or whether they never started and they never progressed into the complete puberty, so that she is not having menarche. So 2 problems to be addressed. So there is a doubtful of primary amenorrhea as per the definition. There is a obesity. There may be separate entity, there may be a single entity which is contributing together for the obesity and primary amenorrhea. So as per the technical background, so everybody knows, everybody think that obesity will cause precocious puberty. If any child having obesity, they have a puberty very early, because there is a critical fat which will act as a pulse generator for the sex hormone for GnRH. They do have more pulses, they have a more precocious puberty. Simultaneously, obesity itself have so much of comorbidities and complications. So because of the obesity, there may be associated increased insulin. So insulin resistance, which may contribute for the production of androgens. So insulin resistance, androgens, there is a disturbances in the negative feedback for LH, FSH. There may be elevated LH, FSH may be borderline elevated or suppressed. So because of this, ovarian cyst may develop, she may have primary amenorrhea. So simple obesity as a chronic morbidity, as a consequence, as a complication, may contribute for the development of primary amenorrhea. That is the one logic behind obesity and primary amenorrhea. And second, most commonly, like everybody think, whenever we are approaching obesity, most of the people think most common cause is exogenous. So first we will put the diagnosis as exogenous obesity. Whenever we want to label exogenous obesity, it is a diagnosis of exclusion. First of all, we have to rule out genetic obesities, syndromic obesities, hormonal causes of obesity, and then taking, depending on the diet history, physical activity, then only we can label a child as exogenous obesity. So whenever we want to approach a obesity child, history, examination are most crucial. So obesity is a condition. You have to take the history of onset, duration, progression, associated factor, obesity related complications, and etiological reasons why child develop obesity. So this kind of history should come. So everybody knows diet is the one thing, drugs, and some especially steroids, antiepileptic drugs, androgens, and some asthmatic medications and anti-tubercular drugs, they contribute for the obesity. So history should come with both like diet and drugs. Simultaneously, you should ask for the etiological, like underlying background of thyroid, maybe any excessive use of steroids or Cushing's features, or many pseudo-hypoparathyroid features, or any androgen secreting tumors, or non-classical CAH, all polycystic ovarian syndrome. These kind of history should be there. So among this, and also there should be a significant family history, and also birth history is also important. SGA babies are more prone for obesity as per the Barker hypothesis. So SGA we should ask, and also mother weight status before pregnancy and at the time of delivery is also most important. If antenatal obese mother or peripartum more obesity, children tend to have more obesity. Coming to the family history, we should ask history related to diabetes, hypertension, hyperlipidemias, coronary artery disease, and these kind of history should come along with the diet of the family history. This is about the history. Next slide, ma'am. So coming to the examination, we are seeing obesity child and primary amenorrhea child. So for obesity, we have to look for the etiological, like hypothyroidism, goiter, any midline defects for syndromic children, any polydactyly, visual anomalies, developmental assays for low IQs, and also acanthosis, striae, stretch marks, hyperandrogenic features like hirsutism, change in voice, or any skin tags. So all this kind of examination we should keep in mind. And also, if it is adolescent more than 7 years, we should check for SMR, blood pressure without forgetting. And if it is peripubertal or post-pubertal, we have to take the help of gynecologist or female pediatrician or female attender to have genital examination, at least to look for any clitoromegaly or local examination. So examination is also most important. Don't take it as a granted. Obesity means exogenous. They require BMI, blood pressure, only waist circumference, and then some investigation. So without doing investigations, we can do much for a children. We can minimize and we can come to a conclusion of the diagnosis. So history and examination is the second most important. Coming to the third. So then it will give a clue whether am I dealing with monogenic obesity, syndromic obesity, endocrine obesity, or exogenous obesity. So depending on these history and examination, I will take a decision to go for investigations. So coming to the investigations, most commonly what we have to do is more common and more treatable conditions. So thyroid is one of the treatable conditions. So take home message is hypothyroidism can contribute to obesity, but the percentage of weight gain will be only 1 to 5%, not more than that. That is roughly 4 to 6 kilos of the entire weight, excess weight is contributed by only thyroid. So that is also because of the fluid retention, sodium retention, that causing excess weight. And in fact, hypothyroidism, they do have low BMI. So low basal metabolic rate. So they have a loss of appetite. So simple hypothyroidism causing excess morbid and severe obesity is unlikely. If it is a mild to moderate obesity, can be contributed by hypothyroidism. So other thing we should keep in mind is either any associated complications because of the obesities. What are the complications? Most common is acute complications and chronic complications. So metabolic syndrome, hypertension, diabetes, arthritis, sleep disturbances, breathing difficulties, maybe period or in endocrine related problems. These are the complications we will think in mind. So because of that, we have to do LFT, lipid profile, and also in LFT, SGOT and SGPT are more important, and fasting blood sugar. And if it is more than 10 years or in early puberty period or any significant family history, we should do OGTT. So, and routine assessment of insulin is not required, but in my practice, I'm doing routinely because it will give a prognostic marker, and we can tell the parents, so this child is having significant insulin, so that he may land up in type 2 diabetes or maybe any metabolic syndrome. So it will be a warning signal for the parents. So without having any lab evidence, whatever we will tell as a endocrinologist or a physician, they will not believe. So on seeing insulin, yes, they will keep in mind, okay, something is going bad. So we have to keep our weight in track. So that's the reason to make them, to fear them, or to make my process and counseling very easy, I will do serum insulin, but not only serum insulin, I will calculate HOMA-IR. So if anybody wants how to calculate, please put it in the chat or to my mobile number chat. I will help you them. HOMA-IR, baseline HOMA-IR more than 1.5 or postprandial HOMA-IR more than 6 is significant. It is a surrogate marker of insulin resistance or pre-diabetes. So these are the baseline investigations. If any Cushing-Gauer features, I will go for serum cortisol. Or if any non-classical CH, I will go for serum cortisol or 17 OHP level. And if it is a suspected polycystic ovarian syndrome in such a child, polycystic ovarian syndrome can present with primary amenorrhea. Don't think it is always present with secondary amenorrhea. So primary amenorrhea can also present. If I suspect, so I'll go for ultrasound abdomen and pelvis to look for fatty liver, renal anomalies, and any polycystic changes in the ovary. So these are the overall investigations what I will do. Okay, so I'm not going to discuss what are the complications secondary to obesity and everything. Ma'am, skip this slide and please move to another slide, ma'am.
So what are the dietary management, Renuka, can you tell us, in this child who had come with a BMI of 28 and mother is worried that the child has not attained menarche? Anything you want to add at this point of time?
Yeah, basically, sir has spoken about insulin resistance, PCOS, non-alcoholic fatty liver disease. Now, all these things, the root causes, refined carbohydrates in the diet. Whenever we do the counseling to the patient, we ask them, how much amount of maida you bring every month? Answer is, no, we don't bring, ma'am. It's very unhealthy. But then remember, you eat that every day in form of biscuits, bread, pav, toast, different types of other bakery products. Then your Indian sukha nashta. Every time, your pizza or burger cannot be junk, but your Indian nashta like shakkarpara, matris, they are all loaded with refined wheat flour, that is maida. Fine. And sugar and dalda. It goes with everyone. So my request to all the parents is start reading the label. How much percentage of that particular food product is providing you fat? How much percentage of refined flour is being provided from that particular food group? So answer to this is, you need to have your diet history to be taken by a qualified nutritionist. Don't rely on, the forwarded messages. Your WhatsApp university is not a qualified university to give a diet plan, right? You have to ask your treating doctor or a nutritionist for same. Very important message. Many a times, even the mothers tell, मैं मेरे बच्चे को नींबू पानी और शहद दे देती हूँ. But your नींबू पानी, endocrinologist sir is there, other pediatricians are there. Do you agree, sir? Just because consuming hot water and lime, your fat is going to be metabolized, or what all stories they create. It is not. It is not possible. So there is no shortcut to weight loss. Number one, there is no fad diet to weight loss. None of the health agencies promote fad diet, right? So we need to plan out your diet, follow the meal timings, have your breakfast. Skipping breakfast is also been associated with the weight loss, right? Most of the time, glycogen depletion leads to fat gain. So we need to give a proper caloric distribution, number one, and then even your breakfast should not be bread, butter, or bread jam. It should be chapati or bhakri, or probably you can have, if you're having upma, add handful of peanuts to that, add green peas to that. Train your child to have protein with every meal, right? Then when you're preparing paratha, add besan to that. So do not send your child to school without giving breakfast. So the glycogen depletion will not make him concentrate what teacher is teaching. It will lead to weight gain. And secondly, I just want to say that, don't depend so much on convenience food. Start preparing your fresh food. So the weight management tips could be, you have to reduce your fried food intake. Red meat should be avoided. Processed food, aerated drinks, bakery products. I usually concentrate more on bakery products because that's something which is, been liked by the kids so much. And then of course the crisp, different types of wafers, kurkure, this is made from wheat, this is made from oats. Now again, what I can say, it is very important for the parents to start reading the label. I can take this opportunity, when you read the label, the first ingredient present in your label is the maximum which is present in that food product, right? People usually talk Maggi with oats. Oats ka number dekhiye, it will be at the end. So it means very minimal, not even 1 or 2% of oats is present in that particular noodles. And you're eating refined wheat flour as the main chunk of your particular product. So fine. So start reading the label, make a sensible choice. And secondly, when your body has gained weight over the period of time, don't expect it to reduce in a day or a two. Most of the time, parents come, even the kids, Madam, wazan kam nahi hua hai. Give me something high protein, give me intermittent fasting diet. They have paleo diet, they read it out on the net. So don't follow Google uncle. Take tips from your pediatrician, endocrinologist, and then go ahead with that. And of course, sweets, maybe you can make a sensible choice. Instead of gulab jamun, you can have rasgulla, which is protein. Make, sevai ka kheer, something which can be made with jaggery and dates. So you can always, as I've stated, you need to be little innovative, and culinary innovation needs to be done, right? And it will be a joint effort of your exercise, properly planned diet, and of course the tips from your endocrinologist. But then whatever the sir has stated, maida, fat is the root cause, or the refined wheat flour and the carbohydrate consumption what we have Indians. We start our day with, basically upma, poha, chapati. We don't eat dal. We just take dal or sambar to, wet our rice. So the protein content is marginally low in all the Indian diets. So try to revise on that. And as the recommendation, now still the guidelines which has come from NIN and ICMR 2020 RDA, they have reduced the intake of fat, visible fat. It should not be more than 20%, and saturated fat should be less than 7%. So ghee can be recommended to the kids. Instead of ghee, you can recommend butter, but do not recommend dalda, that is hydrogenated vegetable oil. That is very bad. It is loaded with trans fat also. And that's it from my side, Preeti. Doctor.
Thank you. So can I ask, same child with a BMI of 28, already Sri Sharam had highlighted about the moderate and vigorous exercise. So this child, what more you want to tell? Because the psychological part of the child and the mother might be one that the child is more obese, her classmates might be talking much about the menarche, missing on things. They might be discussing, they might be talking about the PMS and all those things. And this child has not yet attended. So apart from the physical activity and the wholeness management, holistic approach, how we will do for this child, other than the mild, moderate and vigorous activity which you had planned, Dr. Sri Shalam?
Yes, ma'am. You rightly said that this child is very anxious child. The moment he comes to your clinic and you label him that he's overweight or obese, that is really touching time when you really want to make him comfortable. So make him comfortable, and you can just ask him, are you of the many of the time in Indian families we have that is padhoge, likhoge, banoge nawab, kheloge, koodoge, to hoge kharab. So majority of the parenting, they do these things. So it's better to ask what type of activities he does. So whether he's of the concept, believes in this type of thing, I think it's very important to take them. And we should tell them that padhoge or kheloge, to hoge hoshiyar. So I think such things really make them, get them, open up. Yeah. So very important is taking the history. And before prescription of a physical activity, I tell you, it is a very tough job. Prescribing medicine, majority of the time, diagnosis part is very tough, but prescription of the medicine is very easy because you know the weight of the child, you know the medicine to be given, calculate the dose and prescribe. But in a physical activity, it is very tough. I myself, when I wanted to started my physical activity, I wanted to see what is appropriate. I tell you, I got more confused. It was so frustrating. So many things are to be known. You sit and calculate. You feel that you are poor in mathematics. Ultimately, in frustration, you throw all that things. Luckily, we have so many apps in the current day practice that you can use these apps, calculators. So those things will really help you. So regarding this with an overweight, when you type, you can still not to become judgmental and tell that you're having food overeating or something like that. But it's very important to understand the facts and prescribe in such a way that there is a compliance, whether the child is competent to do such things, whether the things what you're going to tell them, are they doable, or these activities what you're going to prescribe, are they safe? Because it's very important to know whether the child is near to any playground or any place where he can perform. Now, certain prescriptions should not be that you don't tell them such impractical things. You try to tell them to do skating where they do not have a skating rink or a safe place to play. So it becomes very waste of energy and this thing. So know the habits of the child and customize your prescription of physical activities. So it should be applicable. A child who is already overweight, if you directly start asking the bone strengthening by asking jumping and all this thing, that will be very tough one. So be practical, be it overweight or obese. Again, what the thing is, we tell them 60 minutes of activity daily is a must. So along with the dietary management, the physical activities, what we stress upon is this one. And give them a practical plan so that the child expects. You don't tell them that very loss of weight. For example, any child parents might be expecting miracle things happening within a few days and few weeks. So they should know that a vigorous activity and moderate to vigorous activity can reduce the weight by hardly around 2 kgs, might be or maximum of 3 kgs. So that is the thing, what achievable things which you have to be talking about. So in this child, I think if he loves cycling, you can give them tips on cycling. If there's a playground nearby, which he can do, ask them to go for a walk. And whenever you give any plan for a child, it is always successful when you give a plan to the whole family. So when an adult is accompanying with the child, the success rates are more. And if the parents tell them, now it's the time to walk, go for a walk, I think they don't succeed. And that plan doesn't work out very well. But if the child's parent or somebody goes along with him for a walk, I think they develop a taste for it, and it becomes a fun activity. So let them make it the activity a enjoyable one. It should be very, the child should get motivated to go for any physical activity. So these are certain tips what we tell them. For example, yes, ma'am. So whenever prescribing, tell them the facts, because the majority of the children, they're very smart. They do the Googling part. As madam was saying that they are Google mama, Google chacha, or Google uncle, whatever it is. So it is very tough one to.
But I said it's Google auntie.
Yeah. Okay. So roughly you can tell them, like for example, because 1 kilometer of cycling, suppose a child asks how much calories I burn out. It is very tough, because there again, the speed of cycling is important. The elevation of the land is important. How much steep the ride is, and at what is the age and weight of the child. All this matter, because certain children, they do very speedy cycling and they come up and say that, doctor, my calories are very less, but when I do slow cycling, the calories burnt are more. So things which the child should be knowing, that what type of cycling and how they have to do, what of the type of cycling. For example, 1 kilometer running, again, it all depends on the weight of the person. And on average, if you take 1 kilometer of running, you can burn out around 40 to 60 calories. So again, that depends upon the speed and the time taken to complete that. Swimming, for example, you are going to advise a 30 minutes swimming can burn out calories around 120 to 130. So it all again depends upon the weight. For a 50 kg person, that 30 minutes of. So what we have to stress upon is the number of minutes, what is important. So for initial activities, what we want to stress upon is the number of minutes. So to give a prescription, one size does not fit all. It is very tough job actually to prescribe any physical activities. So whatever the child's taste is, you try to find out and give accordingly.
Yes.
I just want to add here one point, sir, with your due permission. Basically, your exercise also increases your resting energy expenditure. That's what we need to educate to the patient. Don't calculate your immediate calories, but consider the day, throughout the day, what you are going to achieve with that 45 minutes or probably 30 minutes of exercise. So your total energy expenditure, resting energy expenditure, that's what we need to educate to the child. And we have to focus more on the sustainable weight loss than the quick weight loss. So that can be the important counseling part, which we all can do it from our side. Like,
true,
yes.
because at the end of 1 month they do it, and then they think that no, I have not lost anything, so they just fall down. They don't want to do it, and again they start from where they were. So very truly a right point taken by both experts who have taken, that the family has to take in the confidence. They should enjoy the activity and they should understand how it is going to lose. So last question to Dr.
And
Kishore.
majority of the time,
Yes,
and
yes.
some of them even have the hope, like, even dancing is very good.
Dancing, yes. Dancing, aerobics.
Aerobics, it's a good activity. So a 1 hour of dancing can has high expenditure, like kuchipudi or even Bharatanatyam or any classical dance. They can be as high as 500 calories they can burn. Even 1 hour of yoga session can burn as well as 180 calories of, they can burn out 180 calories. So let them, even a simple play, be it football, badminton. So all these activities this physical activity does not mean that only cycling, running, jogging, but the regular play what the child does, and make utilize of the PT education things, what they're happening in the school also. Atmosphere is very important. Whether the school has any playground, whether do they have any separate class for physical activity. So all these things do matter. And some simple things can be told, like for example, in the morning when they rise up, avoid using showers. Try to use bucket and lota, so, or a mug, so that the child bends and starts, and ask the parents to do that, and even for brushing, not to use wash basin and this one, but try to use the bucket and lota, which are ancient way of lifestyle in our India. So I think that begins the story where the success story comes from all these things small things at home. Now going to the school also, if there is some, I think the government should make a policy that at least 500 to 1 kilometer radius of the school should be a no traffic zone, so that the child at least walks. The school administration should ensure that the buses are stopped somewhere around 500 meters or somewhere outside the gate. Nowadays, we see that right in front of the gate, the parents are coming and dropping. I think that should be a very bad practice. They should be left somewhere from 8:30 to 9:30 a.m. The municipal authorities, the local authorities should ensure that it becomes a no traffic zone and the child at least gets some distance to walk. So all these things are things which can help any child and make the physical activity more interesting. Such things I think we should encourage in our school children also.
Wonderful, wonderful, Srishalam. Last question I want to ask to Dr. Kishore. This is a boy who had a BMI of 34. So any medications, any surgeries do you want to advise to this child? Yes, Dr. Kishore.
Yeah, ma'am. So just before moving into this presentation, just I want to add one more point to Dr. Srishalam, sir. So psychological aspect also we should cover, being she's an adolescent girl having amenorrhea, period-related issues. So much of psychological stress that itself can trigger not to have a period. So by proper counseling, educating by mother or by other well-wishers can minimize the psychological stress, so that in a free stress-free zone, she may become normal very fast. So coming back to this question, so yes, so just I want to highlight before moving into the pharmacotherapy and surgery. So for treating an obesity child, the first and foremost, whatever may be the cause of obesity, except endocrine obesity, maybe genetic syndromic obesity or exogenous obesity, the first line of treatment is diet, exercise, sedentary lifestyle changes, and behavioral therapy. Along with that, next and the last option is pharmacotherapy and surgery. And we should not aim weight loss for all children. Okay, so weight stabilization is also sufficient. So as per the algorithm shown here, if it is a pre-pubertal 2 to 7 year child, if having overweight, weight maintenance is sufficient. So we are not going to advise weight loss, and we should not expect also. If it is BMI is more than 95th centile, we have to look for any comorbidities and complications. If are there, then we have to advise for the weight loss. Otherwise, still weight maintenance is fine. So take home message, pre-pubertal weight maintenance is sufficient. So for my child, I'll tell at least for another 2 to 4 years, please try to maintain the same weight. So if we give advice for the weight loss, which is not possible, they will come with the feedback. I'm trying, I'm working, I'm maintaining diet, I'm doing physical activity, I'm doing a lot of things and I'm not losing weight. So setting a goal is also an important in weight management. So for a pre-pubertal child, of course, yes, you have to tell weight loss is best. But if you're not able to lose weight, at least maintaining weight is also best, another good option. Okay. So weight stabilization is the pre-pubertal target, whereas peri-pubertal and post-pubertal children more than 7 years, for overweight complication, we will aim for weight loss. If there are no complications, weight maintenance. So take home message, irrespective of the age, overweight, weight stabilization, weight maintenance. And for a BMI more than 95th centile, without having comorbidities also, we should advise for the weight loss, because this is the age where children are more prone for metabolic syndrome, hypertension, diabetes, hyperlipidemia, heart attack, and cancers. So that's the reason. So, and in managing obesity, it is a multidisciplinary and it's a teamwork. So it is not dealt by only pediatrician or endocrinologist. We need a good nutritionist, psychologist, and also exercise therapist and behavioral management. So all together as a composite, we have to work as a team to achieve outcome of weight stabilization or weight loss. So even if we are not able to achieve with this effort, then we should think of medication or surgery. But whereas in adult, they are approved. But whereas in children, are they approved? Now I'm going to tell. So the available option from the pharmacotherapy is drugs, and surgery. So there are multiple drugs which are available like sibutramine, orlistat, fluoxetine, topiramate, junisamide. There are cocaine. So there are multiple drugs, but none of the drug is approved for less than 16-year children. So the drug approved for adolescent is orlistat, and recently upcoming drug is liraglutide, so which is approved for obesity with associated pre-diabetic and diabetic children. So in those conditions only liraglutide can be advisable, and there is no recent data on semaglutide, which is recently approved medication from Novo Nordisk cream, so which is applicable and advisable for only individuals more than 18 to 20 years. So there are no pharmacological drugs which are applicable for weight reduction. Orlistat can be used after more than 16 years, that also for morbid obesity, more than 35, who didn't lose weight even who failed for more than 6 months even after doing multidisciplinary approach, can try for pharmacotherapy with orlistat. Metformin is not an anti-obesity drug, can't be used. If any associated diabetes, can be used as a metformin. It will potentiate the weight loss. It may act as a accelerator for the weight loss, for the weight diet and exercise. So coming to the surgeries, there are different surgeries. So it is not applicable and advisable for all children routinely. It is only applicable and advisable for BMI more than 40 without comorbidities, more than 35 with comorbidities. But after doing surgery, so many complications are there. So we have to look for the complications: growth faltering, psychological issues, and multivitamin deficiencies, protein and fat deficiency will be visible in the children. So we have to look for the complications post treatment, like gallbladder, gallstones, cholelithiasis, liver dysfunction, so eating disorders, loss of lean body mass, and emotional psychological problems, they do exist. So we should not aim for only weight loss. So there are different goals of the treatment: dietary management, exercise, behavioral modifications, pharmacotherapy. To some extent we have to keep in mind whenever we try to manage a case. Coming to the surgery, ma'am, did you put that slide, ma'am, image where showing surgeries? Yeah. So coming to bariatric surgeries, there is a laparoscopic adjustable gastric banding. So as you seen, there is a gastric band which will be done by laparoscopy. It is like most commonly for adolescent more than 18-20 years. The advisable surgery is LAGB. And other surgeries are like Ruix-NY gastric bypass, or biliopancreatic diversion surgeries, or biliopancreatic diversion with duodenal switch surgeries. So there are different surgeries, but in my experience, I have never advised any surgical options. I never look for any pharmacotherapy. Only pre-diabetic metabolic syndrome obesity child, I do advise metformin. I have only one child from last 5-6 years for whom I have advised orlistat, but that was a subsequently leads to treatment defaulter because of the flatulence, oily discharge, abdominal discomfort, and everything. So I have failed. I have tried only one patient on orlistat. So I never tried and never advised any pharmacotherapy as a surgery as an option for the weight loss. Anything else, ma'am? I think I have concluded on the surgeries and everything. Yeah. So yeah, ma'am. So regarding weight loss, we should not keep 10 kilos, 20 kilos. If we ask child, say for example, you are having 20 kilos excess, they will tell, I want to lose 20 kilos in 1 month. Okay, even parents, they will give set a high goals like 10 kilos in a month, which is impractical. And mostly these are the imbibed information like colors or so many ads. They will tell in a month you will lose 15 kilos, 13 kilos. All they are disastrous for the children. Child should not lose weight very rapidly. They should lose only 0.5 kilos per week. That is 2 to 4 kilos in a month. That is advisable. So an initial goal should be 10% reduction of the weight only. Once achieved, new weight should be maintained for next 2-3 months. It's not like a drastic weight loss, stabilization, weight loss, stabilizations. So it is a slow decline curve rather than rapid decline curve is advisable for the children for the weight loss.
Yeah. Right. So diet management, one last word from Renuka, can we hear?
Sir has already stated no fat diet. Even I have stated that. Balance your energy intake. That is very important. Long-term positive energy could lead to, a lot of weight gain. Then, the protein, one of the important macronutrient, which is most neglected. So see to it that you incorporate protein in your every meal. Do not, just cut down on the sugars and fat. Fat-free diet is definitely not an option. For the absorption of your fat-soluble vitamins, you do need fat in your diet. And the recent guidelines published by NIN and ICMR, they have stated that even carbohydrate drastic reduction could lead to a lot of problems. So minimum of 100 to 120 grams of carbohydrate should be consumed by the child. Usually it has been seen that child has been, given eggs or chicken, different types of chicken preparations by the family, and they make child deprived of rice, chapati. You need to consider that the sustainable food system is very important, because whatever you have eaten and whatever you have grown eating all those food should not be deprived, right? So very important. Consider micronutrients also, as sir has stated earlier in his presentation, that micronutrient deficiencies do play a role. Vitamin D, in a country like India, we should not be expecting vitamin D deficiency. But all this digitization has brought the children closed in the rooms, and that has created the vitamin D deficiencies. My another important answer to micronutrient deficiency for all the parents is start consuming fortified staples in your diet. Please look for a F+ signs on your when you are purchasing the oil packet, or if you are purchasing the milk packet, or if you are buying the ready-made wheat flour. They are fortified with micronutrients like iron, folic acid, and vitamin B12. Along with that, your milk is fortified with vitamin A and D, so that will take care of the hidden hunger. And apart from that, there are certain functional foods. They do play a role, like PCOS mein cinnamon aldehyde, your cinnamon plays a role, or viscous fiber in your obesity reduction. So consult your doctor and a nutritionist. If you want to add any kind of a supplement, just do not depend on the television or some kind of advertisement to adapt it for the fat loss. So your carbohydrate, protein, fats is very important. And your food miles, मेरा हमेशा कहना होता है, I always say that आपका खाना पंच पकवान का रहना जरूरी नहीं है, but आपका खाना पंच रंगी रहना चाहिए. Try to incorporate the colors in your diet. Have tomatoes, have red pumpkin. Your South Indian sambar is equally very, very healthy, right? So the another last take-home message is revert to your traditional eating pattern. And very important, you all must have seen this movie. See the amount of food in their plates. Daba ke khana khao. That concept we go, if we go for the social functions, instead of enjoying the taste, we always go stating that ki mere khame kitna kha lu. There was a research conducted by one of the organization. The people who were coming out after having the marriage meal, they were not able to tell what they enjoyed or what they had or what kind of a taste they had, because they were so busy visiting every counter. And that is so mindful eating, portion control is the mantra for your healthy eating. And eat everything and anything in moderation, very important. If you have eaten samosa, give importance that you have it early in the day, so that it is being utilized properly as you are active during the day. If you consume it at the end of the day, then automatically it is going to increase your fat. That's what from my side.
So if there is a will, there is a way. You see Sara Khan, the new heroine on the Bollywood. So she was more than 95 kgs if you see her, and how svelte looking she is. So if there is a will, there is a way. And I thank all my panelists who were expert in telling how holistically we can act together and we can curb this epidemic. Thank you, panelists. And I thank the Secretary of TCB, Sri Krishna, and President,
Dr. Preeti, we have
Anita
a few
madam,
questions.
Anita madam, now questions over to you for the questions. Yes, from
Yes,
my side.
yes.
First, let us finish with Dr. Sri Sailam. Dr. Sri Sailam, a participant has asked the role of gym in adolescence, physical activity. Dr.
Gym,
you can stop sharing.
Yeah.
Stop sharing the screen.
Yeah. Just I'm doing it.
Dr. Sri Sailam, role of gym in adolescence for physical activity.
So generally, we tend to discourage going to gym in adolescent age group below the age group of 18, because the normal physical activities, what we are recommending, the muscle stretching activities and the bone strengthening activities, I think those are sufficient. And majority of the time, the gym is more like a stress and exertion. So, and a growing child, I think gym is not a better option. So we have other methods of physical activities wherein we should encourage them. You can do muscle strengthening activities apart from using the heavy weights. So not advisable.
What is your take on this gym even done by the young people, not adolescents? But see, we lost our favorite star. At least I had a very fan for Shane Warne. Yesterday he died because of gymming. So, and many youngsters post-COVID have died doing gym. So what is your take on that?
Yeah, for any activity, it is always best to take a medical specialist advice. Look at his cardiac status and look at his well-being, very important. But his nutritional fitness, his activities, it's very important to know the cardiac state, because as we are seeing that
also should be certified and qualified. The gym trainer also should be qualified and trained. Just opening mere gym in every nook and corner really is harming many of the young people, I find.
Yes, ma'am. And one more thing is that you should have a check about the license of the gym, because whether they have a CPR, AED machine is there or not, whether the gym trainer is qualified to enough to perform CPR, and the accessibility towards a medical healthcare center. So all these infrastructures, the center that has all these infrastructures and the needs, I think those are the ones where you are advisable to go. And better is take a medical advice. And always now, because of the COVID, we are seeing a lot of complications. I think it is better to avoid in case of adolescent age group. In the older children, again, young adults, I think that depends on the age, his weight, and depends on the physical trainer who is being there.
With you respect, Sri Sailam sir, I want to address this question from my side also. Sir, in adolescent, there is a term called muscle-bone gap. So skeletal unit is not only bone, not only muscle, both together we call it as a skeletal unit. So while children are transition from child to adult during adolescent period, so because of the growth process, there is imbalance. There is a little bit of miscommunication between muscle and bone lengthening, stretching, and everything. So if we advise adolescent children for a gym or anaerobic exercise or lifting exercise, because of the muscle bone gap, chances of fracture, muscle tear, tendinopathies are more common. So because of that, child will get pain and ambulation will be stopped, and rebound obesity will aggravated. So by doing gym, stopping because of some adverse event, and then there will be significant rebound, weight gain will be there. So this is the medical reason why we should abstain children for sending to gyms, at least less than 16. Most of the gym, 90% certified gyms, after 16 only they are allowed for gym. But ideally, after 18, it is advisable for a child to go for gym training. And just I want to add one more point, screen time. And also it should be less than 2 hours for a child, and less than 2 years, it is not advisable. And we have to follow 0, 1, 2, 5 rule. 0 means no calories at all, at least 1 hour's physical training, 2 hours, less than 2 hours screen time. In a plate, there should be 5 good healthy food. So this is the take home message. Thank you.
One of the participants has asked his wife is 40 years old and 95 kgs, and she is reluctant to exercise. Health issues have started and how to handle her. So I think we have already previously explained about the behavior therapy also. There is no choice. Dietary management, physical exercise, and importantly, behavior management. Then the medication and surgery will be the last option. Is that right? Would you like to add something else, Dr. Kishore?
Yes, ma'am. As you rightly said, there are no cut shots for the weight loss. So always there should be physical activity, diet, behavioral, and change in lifestyle.
Thank you, sir. One more question to you, Dr. Kishore. One of the participants had asked to repeat the BMI calculation.
BMI, it's a mathematical calculation, weight in kg divided by height in meter square.
Meter square.
That.
So if he has given a figure,
BMI charts are there that they can just see the.
So probably he's an adult. He says he is about 90 kgs and his height is 6 feet. So that comes to around 1.8 meters, right?
Yes, ma'am.
So 1.8 into 1.8, 3.24.
Just to add that, suppose in some of them, because of the height, again, BMI doesn't hold good in case of, who are well built, bodybuilders and whose height is high. So in those, I think waistline is important. Ratio of.
Yes, sir. Waist circumference is most predictable, and waist hip ratio. Those are the two parameters we should keep in mind. And still, his BMI is 29. So, as per the Indian classification, he fits into the definition of obesity.
And one of the participants has asked, is karate preferable for children below 10 years of age?
Yes, it is aerobic exercise and advisable.
Yeah, and then role of protein supplements in adolescents. Protein supplement, because adults fancy their muscles, biceps and triceps, and they take.
This question is for Dr. Renuka, I think.
Dr. Renuka, yeah.
Dr. Renuka, tell us, because you had already highlighted about the protein and no carb, so that shouldn't be done, she had told. Yes, again, you can repeat that and reiterate, Dr. Renuka.
Yeah, sorry, I couldn't hear the question. What was it?
Dr. Renuka, please highlight about the protein supplements in children and adolescents. And especially in adolescents, they want big biceps and triceps, and they're going in for the protein supplements.
Right.
So what is your take on this?
Yes. Now, basically, the protein supplements are different types available in the market. Some are soya isolates, some are whey protein, some has got creatinine, which has got detrimental effect on the health. So I request is all the adolescents who are doing gym, please consult your doctor and a nutritionist before taking that supplement. Number one. The recommended allowances for protein is 0.8 to 1 gram per kg of your ideal body weight. Suppose you are not doing very rigorous exercise, this much amount of protein is sufficient, which can be managed by the dietary sources like egg, curd, soya, soya granules, and the other secondary sources of protein. Now, basically, egg should be initiated. Those who are non-vegetarian can have chicken, avoid mutton. So the quantity can be, calculated. The intake can be recommended. Then secondly, since it's an open platform, I won't say that you take it on your own. Even if it is whey protein supplement, it's absolutely safe what your gym trainer is telling you. But still, do consult your doctor before taking it, because you're not aware about the hidden micronutrients and hidden, additives which are present in those supplements, which could affect the health. So it is very important, consult your doctor and then start. They are basically meant for the bodybuilders who are doing rigorous exercise where the wear and tear of tissues is very high. And in such cases, or for the athletes or who are doing rigorous exercises or some kind of a sports activity as a professional sports activity, they require protein supplement. On regular basis, you don't need protein supplement. High biological value proteins like egg, curd, even your soya milk or soya bean can be incorporated in the diet.
Thank you, Dr. N.
Yeah.
So someone has asked for the trainer number and dietitian who is having obesity for both kids and adults. For kids, you should better consult a pediatrician or an endocrinologist if they are obese. And for adults also, consult a proper nutritionist and an endocrinologist simultaneously. to handle the situation as a team. That's what we suggest. Dr. Preeti, over to you.
I request Dr. Anita to give a vote of thanks.
At the outset, I thank the IAPTCB team for giving this platform and conducting this webinar. I thank the IAPTCB President, Dr. Sunkoj Bhaskar, and Secretary Sri Krishna for giving us this platform and the opportunity and helping us out. And I thank Dr. Kishore for taking up this topic, and Dr. Sri Sailam also for taking up this topic, and Dr. Renuka for being on the speaker list. And I thank Dr. Preeti for hosting and conducting everything. And this was at a short notice, and I thank everyone. I thank all the participants and audience for your interaction and being present at this webinar. Thank you so much. Thank you, one and all.
Thank you so much. Thank you, Anita.
Thank you so much. And
She had a union and school union, but she left it and she came. Thank you, Anita, so much. And good night to everyone present here. Thank you.
Thank you so much.
Ma'am, special thanks to Preeti ma'am.
Yes.
Thank you. Special thanks to Kishore, Srishalam, and Renuka. Thank you.
Pleasure. You made us a part of this great event. So thanks to you and the entire team.
Thank you, Bhaskar sir. Thank you, Sri Krishna. We'll leave the.
Thank you. Thanks,
ma'am.
everyone.
Thank you.
Stopping the recording.
Yeah, thank you, sir. Thank you so much.
Thank you. Bye-bye.
Bye.
Yeah, ma'am. Thank you.